Dr. Daver, what mutations are associated with adverse outcomes in AML? What are the best time points to check for these mutations, and what therapeutic options do you consider for patients harboring these mutations?
This is very, very important. Mutational directed therapy is probably the biggest overarching change that has occurred in acute myeloid leukemia in the last decade. And of course, to implement those therapies, one has to know the mutational profile. The 5 big mutations that whenever I speak to my patients in clinic today that I talk about wanting to know before I embark on any therapy are FLT3 or FLT3, IDH1, IDH2, TP53, and now more and more recently, NPM1 or MLL. So actually 6 different mutation cytogenetic aberrations. And the reason is that we do have targeted therapies for these mutations. Some of these targeted therapies are already approved in the frontline setting, like the FLT3 and IDH inhibitors. Some of these are being evaluated in ongoing phase 3 studies, like the CD47 antibody magrolimab for TP53, as well as the menin inhibitors now in the frontline setting in combinations with intensive chemo or HMA venetoclax for MLL NPM1. But I think identifying these targets and getting the patients on the right clinical trial personalized to that target for them has historically shown significant improvements, 20 to 30% survival improvements in FLT3, IDH, and potentially for the TP53, MLL, NPM1. So definitely on newly diagnosed, I would recommend getting that information and then going on to either standard of care if the drug is already approved or a clinical trial that incorporates that targeted therapy or immunotherapy for a target. In the relapse setting, the 2 most important mutations today, or the 3 most important, are FLT3 and then IDH as well as MLL NPM1. FLT3 inhibitors like gilteritinib are already approved. Similarly, IDH inhibitors and combinations of gilteritinib or IDH inhibitors with venetoclax or azacitidine are really showing very good outcomes, even in relapsed FLT3, which about 20 years ago was a very, very, very poor outcome. Today, we can get up to 80% of these patients to remission, half of them into transplant, and a good number may have long-term survival post-transplant. So it's very important to not miss a FLT3, IDH1, IDH2 relapse setting. And then now with the menin inhibitors, we're also looking in all our patients for MLL rearrangement, NPM1 and relapse, because this could open the door for menin inhibitor-based therapy, which again can give up to 50% remission and a path to transplant. And we have now many patients at MD Anderson who have gone through menin inhibitors transplant and are alive, ongoing at 2 and 3 years. My activation tip for this question is it's important to check for mutations in the frontline setting. Absolutely. These include FLT3, IDH1, IDH2, TP53, NPM1, MLL. This list will likely continue to grow as we get more targeted therapies and immunotherapies and find benefit in particular subsets, but also in the relapse setting to not depend on the baseline molecular profile, because the molecular profiles actually can change. We do see AML as a multi-clonal disease, and there can be emergence and escape of different clones. So to check again in the relapse for those same mutations, and both in the frontline, the relapse setting, to try to get onto a therapy, whether it's FDA approved or a clinical trial that incorporates those targeted therapies, which has historically shown a significant improvement in both response and long-term survival.